Hey guys, this is with Nursing School Made Easy. As always, we're doing this lecture again to prepare you for the nclex exam, so I'm going to make it very brief and as basic as I can just to hit you with the main points. Again, just another shout out to Artec Computer Repair. Thanks again for the iPhone 6. I've listened to a couple of lectures and I think the audio quality is better than in my previous videos. So let's go ahead and get started again on hyperaldosteronism. Let me see if I can switch my lighting here so we don't have such a glare. So let's focus again on hyperaldosteronism, and let's just always try to break down the name. Hyperaldosteronism. Now, as the name implies, there's going to be an increased secretion of aldosterone. Now, we've already talked about how aldosterone causes the kidneys to retain sodium. That is one of the biggest things. And the other thing that it causes is it causes the kidneys to begin to excrete potassium. So that is going to be the focus on this lecture. So again, hyperaldosteronism is an increase in aldosterone secretion. Again, this aldosterone is going to increase sodium retention. And the other thing that aldosterone is going to do is it's going to cause potassium excretion. So you will end up with hypokalemia. Now, what will sodium do? Remember that if you have increased sodium retention, chances are water is going to follow. Now, as a result, you will have increased blood pressure, or patients will suffer from hypertension. So that is a huge thing to remember. Okay, these patients will suffer from hypertension. So that is a result of increased sodium retention. Now, the problem with potassium excretion is, of course, hypokalemia. So these are the two things they need to focus on. Also, this will cause alkalosis. So a couple of main things to remember is hypokalemia, hypertension due to hypernatremia, and alkalosis. Now, what is the cause of hyperaldosteronism? One of the main reasons is some type of adenoma. In this case, adrenocortical adenoma. Number one, and number two, some type of chronic kidney disease. Now, this could be maybe due to, for example, diabetes. Okay, patients with diabetes, or especially with uncontrolled diabetes, will end up with renal failure. So that would be a chronic kidney disease. Okay. So now let's focus on some signs and symptoms or clinical manifestations that these patients will show. Number one, we kind of already briefly mentioned it, is hypernatremia. Number two, hypertension. Again, caused by the hypernatremia. Make sure you know that or remember that for the NCLEX exam. 3, headache. Now this is going to be most likely due to increase in blood pressure, severe increase in blood pressure. That again will cause the headache. Number 4, hypokalemia. Now with hypokalemia, you're going to have muscle weakness. You will have fatigue. And the big thing that you need to be aware of with hypokalemia are the cardiac dysrhythmias that can occur. And as always with these patients, you want to make sure if the hypokalemia is severe, they put them on telemetry or EKG. And that you're always checking for chest pain. Especially if they're having very high blood pressure. And the other thing that we talked about up here is metabolic alkalosis. So what are some diagnostic studies for these patients? Number 1, we talked about how this could be caused by an adrenocortical adenoma, some type of mass, some type of tumor. So one thing that can be done, maybe perhaps a CT or an MRI to find out where that mass is. The other thing that you'll look for or do, just make sure you know this for the NCLEX, is 18 hydroxy corticosterone levels. So again, 18 hydroxycorticosterone levels. You will check for these levels, and these levels will be increased. So these will be greater than 50 nanograms per deciliter. So anything above 50. Now again, this is going to be very specific to hyperaldosteronism. This is kind of a very long name to remember, so if that helps you remember it, the 18 in it, again, that will tell you that it is hyperaldosteronism. And again, the level is greater than 50. Now this will typically indicate that there is some type of adenoma present. Okay? Now let's focus on treatments and interventions for these patients. Number 1, an adrenalectomy can be performed. Or removal of the adrenal gland. That can be resected. Now, if the adrenal gland is resected, you have to remember about all the different complications that can occur. So please revert back to the lecture on Addison's disease, maybe on Cushing's. Now, if these patients are going to undergo some type of surgery, again, to remove the adrenal glands, hence adrenalectomy, you're going to have to prepare these patients for surgery. So you're going to have to pre-op them. So there's going to be a couple things that you need to do. Number one is you're going to have to decrease their sodium intake. And the decrease in sodium intake will be for a patient that is suffering from hyperaldosteronism, whether they're going to surgery or not. Because remember, in hyperaldosteronism, you're going to have hypernatremia. So in either case, you're going to have to monitor their sodium intake. You definitely don't want them consuming more sodium, making them even more hypernatremic. You may give a potassium sparing diuretic. Because again, aldosterone is going to cause potassium excretion, making you hypokalemic. So if you're going to give a potassium sparing diuretic, you want to make sure that, again, it does not get rid of potassium. Therefore, it will be a potassium sparing diuretic. The reason you're giving a diuretic is to hopefully bring that blood pressure down. Because again, along with the sodium retention, you're going to have water retention. And the potassium sparing diuretic of choice may be something like aldactone or spironolactone. So make sure you know this for the nclex, okay? Now, something else can be done. Potassium supplements may be given. This can be oral or IV, depending on the amount or the severity of hypokalemia. But most times you will not give these two at the same time, because if you have a potassium sparing diuretic like spironolactone or aldactone, that on its own is going to bring potassium levels up. And if you give potassium supplements, that also is going to bring their potassium levels up. So if you give both of these at the same time, you have a likelihood of causing hyperkalemia. Okay, so you always want to make sure that, again, you're monitoring potassium levels. So that is another intervention. You will monitor these levels, especially if it ends up that you do give these two things at once. Another medication that may be given is something like Inspra. And it has a similar effect as aldactone, okay? Inspra. Now, with these patients that are taking Inspra, you want to tell them to avoid grapefruit juice. That is very important. Now, these patients may be given something like a calcium channel blocker. Now, the reason for that is to bring down the blood pressure or to decrease hypertension. Now, I forgot to mention one thing about aldactone. Put that down here. One thing that you have to inform your patient of, or your male patients, is that it can cause gynecomastia. So you must let your patient know that. It can also cause impotence. And in women, it can cause menstrual disorders.